Good evening, everybody. Thank you for joining us this evening to this webinar, Understanding and Pursuing Health Equity Opportunities to Take Action. My name is Efraim Flores, and I'm a radiologist at Massachusetts General Hospital, where I also serve as Officer for Community Health and Equity in the Department of Radiology. Tonight, first, I just want to thank our sponsoring institution, the American Medical Association, and the American College of Radiology, particularly the Population Health Management Committee that is under the Patient and Family Centered Care Commission. I also want to thank all the staff at the ACR and all the speakers and panelists that are joining us tonight in this discussion, and to all of you that are participating in the great panel tonight. We're going to start with a couple of housekeeping items. First, just remember to try to keep yourself muted while we are having the presentations. And if there's anything that you are missing or need to catch up later, the webinar will be recorded and posted online at a later date for everybody to review. Please submit your questions via the Q&A panel. And if there's any technical issues, also please let us know via the Q&A panel as well. There are no disclosures to report for the webinar planners, administrators, panelists, and speakers. And in order for you to receive credit for tonight's presentation and successfully complete the activity, a participant must complete an evaluation and claim credit commensurate with their participation in the activity. And after the activity has concluded, participant will receive an email from ALA account at acr.org with a link and credit to claiming continuing education credits. Participants will have 3 months post this activity to complete and claim the credits. I also wanted to use the opportunity to let you know about other health equity related resources that the American College of Radiology has currently available. One is the JACR, the Journal of the American College of Radiology, Health Equity Special Issue from 2019, where we have a collection of several articles that are high priority topics for health equity in radiology. We also have an upcoming special issue from the Journal of the American College of Radiology on Health Equity and Social Justice that is coming in 2021, with submissions due at the end of October. Also, the American College of Radiology has an ACR bulletin on special issue on health equity of this month in September 2020. And there, I just wanted to quickly remind everybody that the speakers will give their presentations, and at the end of the presentation, we'll have a live Q&A session where we can ask all the questions to the speakers. We'll have a live discussion from them. Now, I would like to introduce my co-moderator for this evening, Dr. Lucy Spaluto, who is an associate professor of radiology at Vanderbilt University Medical Center, where she serves also as vice chair of health equity. She and I will be co-moderating tonight's webinar. And please welcome Dr. Spaluto.
Thank you, Dr. Flores. Thank you for that wonderful introduction to tonight's webinar. And it is terrific to see such a mix of folks joining us tonight, because as we know, it takes a team-based approach to form a community dedicated to advancing equitable care. So I'm glad to see that we have patients and patient advocates and clinicians from many different specialties in attendance, because we will need all of your leadership in this work. And a big thank you to our sponsors for tonight's event, the American College of Radiology, the American Medical Association, the Patient and Family Centered Care Commission, and the Population and Health Management Committee. Speaking of patient advocates and patient advocate leaders, I would like to now introduce our first speaker for the evening, Andrea Barandi-Kitts, who is a lung screening advocate and a lung screening program leader at the Leahy Clinic in Connecticut. She is also the associate editor for Patient and Family Centered Care with the JACR. Andrea is going to share patient stories and perspectives throughout our time together tonight. So thank you so much, Andrea, for kicking us off and keeping us focused on the patient.
Thank you for the kind introduction, Lucy. So I'm going to go ahead and share my screen. Oops. There we go. Okay, so I'm going to talk about addressing health disparities from a patient perspective. I'm really pleased to be here, and really thank you very much for inviting me to be part of the webinar. These are my disclosures, but they have nothing to do really with what I'm going to be speaking about today. Okay, part one. I'm going to tell you the story of someone who fell through the cracks. As you know, many radiology procedures are ordered by other clinicians, both from hospital and outpatient settings. Most of these require some notification of results as a minimum, and sometimes there's follow-up as well. Results notification and follow-up, these are typically done with the referring clinician, and it's assumed that they will follow up with the patient. This often works well with people that have a usual source of care, but not always so well for those that do not. I was working with a cardiothoracic surgeon friend to help him start a lung cancer screening program at his safety net hospital in the Trenton, New Jersey area. He decided to start by establishing a lung nodule clinic. He had his staff go through the medical records of patients to identify incidentally found lung nodules that had not been followed up on. One of the recent incidental nodules was for a man, John, that had gone to the ER for shortness of breath. His chest x-ray showed something concerning, a mass in his lung. The ER doc told the patient about the finding and told him it was important for him to follow up in the next several days. The record review for the nodule clinic showed it had been several weeks since the patient left the ER and there had been no follow-up. The phone number the patient gave had been disconnected. The nurse doing the reviews of incidental nodules was concerned, and she actually went to the home address the patient gave at the ER. No one answered the door. So she went door to door, asking the neighbors if they knew John and if they knew where he was. She eventually tracked him down, and she expressed her concern that he had not followed up on the lung finding. John said, "But I did follow up. I went to the ER every single day and asked them about my x-ray and what I needed to do. But they had no idea what I was talking about." See, John didn't have health insurance, and his usual source of care was the ER, so that's the only place he knew to go. There are many challenges for individuals with no regular source of care. One is that they may not get regular health screenings, including cancer screenings. We know that 80% of individuals get cancer screening because their doctor tells them to. But if they don't have a doctor, they may not know they should be screened. John's lung mass was incidentally found, and unfortunately, it turned out to be late-stage lung cancer. John did not have health insurance and never went to the doctor. Like many in his situation, he only got care for acute conditions, usually at the ER. By the time his lung cancer was found, it had metastasized and he had limited treatment options. But even if individuals have health insurance and a source of care, access to covered care may not be equal for those at equivalent risk. Disparities exist in eligibility for coverage. For example, CT lung screening is recommended for individuals at high risk. Unfortunately, the eligibility criteria, smoking history, pack years of smoking, and age, do not apply equivalently to Blacks and whites. Several recent studies show that Blacks are less likely to be eligible for screening despite being at equivalent risk to whites because they have different smoking behaviors. They smoke fewer cigarettes per day, less likely to quit. Most are diagnosed at an earlier age. In fact, about half as many Blacks are eligible for screening as compared to whites. Black men have 1.2 times the risk of dying from lung cancer as whites. If we don't change the criteria for screening, this disparity will only get bigger. This is just one example of how health disparities are manifested in our current healthcare system. When I come back later after a few speakers, we're going to talk a little bit about what we can do to help address this. Thank you.
Thank you, Andrea. Thank you for reminding us how challenging it can be to be a patient in our healthcare system and for bringing us that patient perspective. Our next speaker tonight is Dr. Fernando De Mayo. Dr. DeMaio is the Director of Research at the American Medical Association's Expanding Health Equity Division. We're very grateful to have him here with us tonight and to have the sponsorship of the American Medical Association. Dr. DeMaio is also a professor of sociology at DePaul University, where he was the founding co-director of the Center for Community Health Equity. Welcome, and thank you for sharing your discussing comparative and historical perspectives on health equity.
Great, thank you so much. It's a pleasure to be with you tonight, and I'm looking forward to our conversation. Andrea, thank you so much for those opening remarks. I think what I'd like to do with my bit of time is really to zoom out, to look at populations, public health measures in general, and add a little bit of history as well to how we think about health equity work. So at the AMA, we have a very new Center for Health Equity. This was established just last year after a House of Delegates resolution calling for the AMA to take a fundamentally stronger presence in health equity work. Our vision is, I think, quite striking, and I want to share it with you. It's a nation where all people live in communities where resources work well, systems are equitable and create no harm, and everyone has the power to achieve optimal health. And this second clause is I think, equally important, right? Where all physicians are equipped with a consciousness, tools, and resources to confront inequities. That for me is fundamental, right? And data and research play a vital part of that consciousness raising, right? The tool generation and the resource and capabilities. The mission of the center is to strengthen, amplify, and sustain the AMA's efforts to eliminate inequities, recognizing that these are rooted in historical and contemporary injustices and discrimination. We work under 5 strategic approaches of embedding health equity throughout the organization, building alliances and sharing power via meaningful engagement, ensuring equitable opportunities and conditions and innovation for marginalized minoritized people and communities, pushing the healthcare system upstream to address all determinants of health, and creating pathways for truth, reconciliation, and healing for the historical trauma that we have witnessed in this country. For me, health equity comes down to this, right? The fundamental idea that your zip code shouldn't predict how long you live, but it does. It does in my home city of Chicago, it does in San Francisco, it does in Dallas, Texas. And it's not necessarily just a US phenomenon. We see this in other countries as well. These are some data from my home city of Chicago, which I think are quite striking. We have gross inequalities and equities, in this case, an infant mortality rate amongst our 77 designated community areas. For me, the big issue, the fundamental challenge is that things haven't really changed over time. Yes, every community is better off now. We have lower infant mortality rate, higher life expectancy. But the fundamental problem of health inequity is the difference between these areas, right? Differences that are avoidable, unnecessary, and unjust. So over time, every community is better off, yet the relative inequities remain and sometimes even grow. More and more, we're recognizing the limitations of the healthcare system, which is entirely geared towards downstream issues, medical needs, mortality, disease and injury, and risk behaviors. But more and more, in fact, in the past 25 years, I would say that there's been an entire movement around the world recognizing the importance of living conditions, whether it's the physical environment, the social environment, the makeup of our communities, the institutional inequities that shape those living conditions, and then furthest upstream, the social inequities or the systems of power and systems of oppression in our society that fundamentally shape population health. Let's look at some data. These are data on all-cause mortality, age-adjusted for the entire United States. 762 people per 100,000 will die every year. It's really important to recognize the remarkable variance and inequality that exists between our major cities. Right, from our healthiest cities like San Francisco and San Jose, to cities like Las Vegas, Baltimore, Detroit, and even Memphis, which is not often on these kind of lists, where mortality rates are way higher than they are in our best off cities. But this, of course, hides many of the inequities within the cities. So some of this work, and this is work that I've been doing with a fantastic colleague named Maureen Benjamins at the Chicago Sinai Urban Health Institute. We've looked at Black-white inequities, looking at rate ratios in these measures. So across the United States, the rate ratio for all-cause mortality is 1.23. Black Americans die at a rate of 1.8 times the rate of white Americans. And again, we have remarkable inequality between our cities. Cities like Washington, D.C. have a mortality rate ratio greater than 2. My hometown of Chicago is 1.58. And we've known about this problem for a very long time. One way of really understanding these figures is to calculate excess deaths, which take into account not just the relative gap between groups, but also the size of the population affected. And so by that measure, Chicago is particularly poor, with 3,500 excess Black deaths every year. Now, contrary to popular myths, this is not as a result of homicide and gun violence. Most of these deaths, the majority of these deaths are chronic disease, right? They're heart disease, they're cancer, and they're diabetes related. And we've known about this for a long time. These are our latest data. This was the headline in the early 2000s in the Chicago Sun-Times. We can also begin to unpack inequity stories by looking at not just overall all-cause mortality, but by looking at disease-specific mortality as well. Here, cancer is relatively more equal than some of the other major killers. Kidney disease, diabetes have rate ratios greater than 2 for the United States as a whole between Blacks and whites, followed by stroke and heart disease. Alzheimer's, accidents, respiratory disease, and suicide actually display a Black advantage where the rate ratio is less than 1. Now, none of this is natural. It's all produced by policy. It's produced by those systems of oppression that we had in the causes of the causes figure. And they're historically entrenched. For as long as we have had data, we have had health inequities, sometimes with a 20-year lag, right, between the Black rate and the white rate. I think critical for understanding this is that we take a holistic picture. So one quote that I'd like to share with you, our patients represent the crystallized oppressions of our society as expressed in illness. What you're seeing here are the most oppressed of our society, the most vulnerable, the least equipped by education, by birth, and by economic resources to resist the numerous oppressions of our society, from the air we breathe to the nasty housing that the poor are condemned to, and it ends up in all variety of diseases. The conclusion you draw from that analysis is that you're dealing with a total societal failure. And working with a health question, you can begin that transformation that will make us more civilized than we are. This was Dr. Quentin Young in 1979. And we are all still struggling with Quentin Young's challenge, right? Working with a health equity question to make us more civilized than we are. For me, the fundamental concept underpinning all of this is structural violence. Paul Farmer has been the most eloquent writer in that level, describing structural violence as social, political arrangements that harm populations, embedded in the political and economic organization of the world, and the violent because they cause injury, they cause harm to people. And to be sure, all of this is depicting the true effects of racism in society. It is not racial differences. Race is not a biological category that naturally produces health disparities because of genetic difference. Race is a social category that has staggering biological consequences because of the impact of social inequality on people's health. What if doctors joined the forefront of a movement to end the structural inequities caused by racism, not by genetic difference? It's a question posed by Dorothy Roberts in 2015. To conclude, some signs of hope. More and more medical schools are incorporating structural competence and anti-racism into the curriculum, equipping and training physicians, supporting physicians to possess a critical knowledge in the production of inequities. An entire new generation is challenging medicine to focus on racism and not race. Institutions, healthcare systems across the countries have issued statements denouncing structural racism and vowing to enact real change. And more data are available than ever before in public health and in medicine to diagnose and track problems over time. And lastly, one sign of hope that I think we all share is that there's widespread discontent with business as usual, right? And the recognition that it would be unethical in health equity work just to describe problems, that our task really is to work together collectively to overcome these deeply entrenched but solvable problems. Thank you so much for your time. I look forward to the discussion.
Thank you, Dr. De Mayo. Tremendous discussion, very powerful message. Now I would like to introduce Dr. Joseph Betancourt, who is the Vice President, Chief Equity and Inclusion Officer at Massachusetts General Hospital. He's also founder and senior advisor and faculty at the Disparities Solutions Center and the Mongan Institute. And he is Associate Professor of Medicine at Harvard Medical School and also a good friend and mentor. Dr. Betancourt, welcome to the panel tonight.
Fantastic. Thank you so much, Efren, for the kind introduction. And thank you all for taking time on a late evening here on the East Coast, at least, and appreciate everybody being engaged in this conversation. Again, it's an honor and a pleasure to be part of this discussion with my esteemed panelists, and want to especially thank all the organizers and the ACR and everybody who's involved in putting together what really is a phenomenal panel. Maybe I'll just take a minute to tell you a bit about what I do, the lens from which I'll be speaking, and a little bit about what brings me to this work. So I am Vice President and Chief Equity and Inclusion Officer at Mass General Hospital. I started that position last May, and prior to that, I've been at Mass General for almost 20 years as a primary care physician, and up until recently led a place called the Disparities Solutions Center, where we work with hospitals, health plans, health centers around the country to better identify and address racial and ethnic disparities in health and healthcare. What brings me to this work, I'm originally from Puerto Rico, grew up in a bilingual, bicultural home. The issues of race, ethnicity, culture, and class, and how they interact with society, and certainly healthcare, are issues that I've experienced personally, experienced with my family and friends, and certainly experienced as a trainee and a physician. And so I've dedicated my career quite simply to figuring out how we could make sure we're delivering high quality care to anybody who enters our door, no matter who they are, where they're from, with the understanding that we can't only do it inside our doors, but we need to think about ways to engage a community in ways that I believe bring a doorstep to bedside approach to equity and care. Now, I'm going to share some comments and some perspectives and some lessons from 2020 related to structural equity from the lens of the work that I embarked on in March 16th, to be exact, as I was asked to lead Mass General Brigham, our parent system's efforts on equity as it relates to our COVID and COVID preparations, and also help lead Mass General Hospital's areas efforts in equity. And then we combine them with equity and community health. So my reflections will really, I think, be based on a couple of key things that I'd like to highlight. First, there's no doubt that in this past year, we have experienced two seminal events that have fundamentally changed the landscape of health equity. They include certainly COVID-19 disproportionately impacting communities of color naturally. We've talked extensively, and if you've read anything in the lay media, you've understood the perfect storm as to why COVID has impacted communities of color disproportionately. This is not about genetic susceptibility. This is about communities who entered the pandemic on a foundation of structural racism, significant negative social determinants as part of their daily life, and already at a disadvantage given that we knew that COVID would disproportionately impact those, for example, who experience disparities. And so the higher burden of disease, the foundation of structural racism, the foundation of the disproportionate impact of the social determinants, all put communities of color at higher risk. That was then compounded by the fact that when we think about essential workers, communities of color were the definition of essential workers and tended to live in environments that included densely populated areas, multi-generational homes, and again, needing to go to work when many of us could socially distance and get groceries delivered at home, and being on public transportation, for example, before we were telling people to wear masks. So this for us wasn't just an issue in Massachusetts and places like Chelsea and Revere and Lynn in the shadows of Mass General and our Mass General Brigham system where we had these hotspots, but this was the story of Queens, New York, Chicago, New Orleans, Los Angeles, Milwaukee. And again, this, I think, became a story for us and fundamentally changed how we thought about this perfect storm. On the heels of us in Massachusetts coming off the surge, clearly at the end of May, we then got a chance to witness, after fighting so hard to literally help people breathe, yet another episode of violence and racism taking the life of a Black man, a history of taking the lives of Black men, women, and children for centuries, but again, in the most acutely painful way, as we had fought to help people breathe, and then we had a chance to watch somebody have the breath squeezed out of them in a way that I think created a national reckoning on racism, certainly that I had never seen in my lifetime. And so these two seminal events, I think, have highlighted the impact of historical racism, structural racism, including in healthcare, the social determinants of health, and disparities in health and healthcare. And there are a series of key lessons from these experiences that I believe lay the groundwork for creating a more just, equitable society and healthcare delivery system. And I think, as was just articulated, this time calls for meaningful change, executed with urgency, and breaking from previous norms that include unclear targets, limited accountability and resources. I would argue the inability to have hard conversations or use words like racism. And I think the drip, drip, drip of change that for many of us who've spent careers trying to make the business case for addressing disparities, the cost, quality, safety, value case, it has presented an opportunity. We can fundamentally leverage the moral case for addressing equity and disparities in ways, again, that I think I certainly have not experienced in my career dedicated to this topic. So it's with that with humility, but with a lot of passion and dedication, I would like to now share some key lessons for us. Now, these are reflections that I believe should serve as a foundation for where we go as a healthcare system, because certainly we stood up a whole series of work streams, as many healthcare systems did across the country, to address the challenges that COVID presented. But the true courage in these efforts will be, I think, proven if we sustain these changes and fundamentally transform our healthcare system to make it more equitable. So let me begin with lesson one. There is no doubt that as we think about emergency preparedness, history tells us fundamentally that man-made or natural disasters disproportionately impact vulnerable populations. We need to be more deliberate and more discerning and incorporate an equity analysis into emergency preparedness. Now, I'll say that I was someone who certainly was worried about the impact of COVID on vulnerable communities, but I didn't necessarily connect the dots the way I could connect them a couple of weeks after the pandemic started. So what is the lesson here? Communities of color were hit early, hit hard, and we're in the perfect storm. So fundamentally changing the way we think about emergency preparedness is critical. Second, we need to absolutely incorporate race, ethnicity, and equity measurement in all of this work. So in everything we do, and that includes surveillance, now that we're in the peri-COVID period, still in the midst of the pandemic, in monitoring, in dashboards and reports, as these serve as a springboard for fundamental action. So it's critical that we build the tools and have the race and ethnicity data collection and other metrics, the concept of big data, to be able to target interventions and move fast. Third, as we redeploy for emergencies, language capabilities are an asset. By that I mean my ability to speak two languages allowed me to engage at the bedside as part of something we created called a Spanish language care group, an effort that was stood up in response to 40% of our COVID positive patients being Spanish speaking, understanding that our interpretive services would be overwhelmed. We had the foresight to create a multilingual registry where we tried to get individuals to put forth their language capacities, doctors, nurses, frontline staff, researchers, with the idea that as we were redeploying during COVID, we would be able to leverage language as an asset. And so we were able to do that in a variety of ways through our multilingual registry, through our Spanish language care group that Dr. Flores was also a part of, by identifying individuals who could serve as trusted messengers for delivering information to communities. And ultimately, I think what's grown from this is a fundamentally different understanding of the importance of diversity. Not a nice to do, but through those 6 weeks where over 50 native Spanish-speaking doctors from 15 services in 15 countries stood shoulder to shoulder 24/7 with our surge teams, our colleagues who cared about diversity understood the importance of the clinical, cultural, and linguistic competence we brought to care in ways that they, I think, never imagined, and they have become our biggest supporters. So again, language needs to be considered as an asset, and it is a quality and safety issue. Number 4, as we evolve clinical care, we need to assure equity. And certainly COVID led us to need to be responsive through hotlines and provide information to patients, and certainly the deployment and evolution of virtual health and the use of the electronic health record. But ultimately, those hotlines needed to be staffed by individuals who spoke different languages. We needed to make sure that as we provided information to patients, it was multilingual. It was focused on individuals with disabilities. It was a level of low health literacy. As we launched our virtual health efforts, we needed to acknowledge that the digital divide was fundamentally preventing many of our patients in vulnerable communities from being able to get on Zoom to connect with their doctors or Doximity, and were really relegated to just a telephonic interaction with their caregiver. And fundamentally, as we used our electronic health record to put information out, again, the digital divide and the amount of individuals from vulnerable communities who are actually on our patient gateway limited their ability to get information. So we needed to address all of this. And these are disparities that we have lived with for years, and we haven't, I think, drawn enough attention to. So this is a key lesson for action. Lesson 5, we need to care for those within our walls, and communication is key. So we focused a lot of our community health efforts on our vulnerable communities, but there's no doubt that within our nutrition, food service, environmental services, materials management, buildings and grounds, we have individuals from those communities, from our communities who are in our midst, caring for them, identifying their social needs, giving them the information they need as they become trusted messengers in their community. Ambassadors for this work really is a critical lesson for us, and something that we elevated and launched an emergency text messaging platform, for example, to democratize the information that our employees were getting. Because many of us were getting it via email or Zoom, yet a whole group of our employees, particularly from vulnerable communities, were getting information unevenly from their managers as best as they could, oftentimes in a way they couldn't understand, or in a language that wasn't one that they could dock in on. Lesson 6, the social determinants of health will always worsen in the case of disasters and hasten spread in the case of a pandemic like this. So community health needs to take a doorstep to bedside approach. Food insecurity, the rise of evictions, issues related to housing insecurity all got worse. And they create, again, this perfect storm that hastens spread. So any efforts to diminish spread really required us to not just focus on ventilators and bed capacity, but deploy a community-based approach, not just to meet social needs, but also to decrease spread. So for example, we deployed care kits and basic bags with masks and hand sanitizer and cleaning supplies to individuals who had difficulty socially isolating in crowded homes, isolation sites where they could do that safely, where we could staff, a hotel that we were able to take over, a convention center. So ultimately, this concept of doorstep to bedside becomes critical. And I think to this day, we've still now, I think about deployed over 1.5 million masks, over 750,000 care kits in our hotspot communities. I'll end here by saying that we must have equity in all efforts. These are the key lessons from COVID-19. Now we pivot on to racism and structural equity, and I'll just go through these quickly, and I think my colleagues will touch on these some more. There is no doubt that structural racism is deeply embedded in healthcare. It's in clinical policies, HR policies, racialized medicine in our clinical guidelines. These need to be identified and addressed in a deliberate way, with targets, with due process, but ultimately these things are under the radar for many, but acutely painful to many as well. And so I think that's a key lesson that we take post the George Floyd era. Caregivers experience daily transgressions, microaggressions, direct racism, again, based on their race. So if we espouse values of respect and dignity among our patients and our caregivers, our inability to report and reconcile these issues in a trusting way limits our ability to live our values. So ultimately, caregivers need to be cared for, and creating reporting and reconciling mechanisms for our patients, but for our caregivers is critical. Lesson 3, there is a little understanding of our national and local history as it relates to healthcare, equity, and racism. And we are launching, like many institutions across the country, a training and learning pathway that is mandatory, customized, and that is built to I think, leverage us as a learning organization, but to make us a better organization and transform how we think about race and its impact on health, well-being, all aspects of our society, and the care we deliver. Now, I'll just say that this is currently under threat, as you all know, by an executive order out of this administration that aims to limit training in any of these areas. Lesson 4, disparities in health access and healthcare persist And we need to bring resources and rigor to this work. This cannot be done at the margin. It can't be left as a nice to do. We need to bring the same energy that we do to quality and safety and other initiatives to this work. Inequality is a health problem. In so much as we don't raise our voices about the importance of living wage, educational advancement, access to care, social needs, these are shared responsibilities that come and we see them in our emergency rooms. We see them in all aspects of the care that we deliver. And so raising our voice here is critical. And then finally, on diversity in healthcare, we are not missing by a little, we are missing by a lot. In the boardrooms, in the C-suite, among our doctors, among our nurses, among our mental health care providers, there is not a place where I believe we are well represented today. We can no longer have hopes and dreams and aspirations about this. We need the courage to make commitments and execute and hold ourselves accountable for outcomes in this area. So I'll end by saying that critical to all this work is communicating what we stand for and advocating for it. I look forward to this group's engagement and to our discussion, and I thank you so much for this time.
Thank you, Dr. Betancourt. Thank you for sharing about your personal journey and sharing those very practical lessons learned from 2020, which has been such a challenging year. I'd like to introduce our next speaker, Dr. Consuelo Wilkins. She is the Vice President for Health Equity at Vanderbilt University Medical Center and Professor of Medicine and Associate Dean for Health Equity at VUMC. She is a nationally recognized thought leader in health equity and in addressing the elimination of systemic inequities that impact the health and well-being of racial and ethnic minorities. On a personal note, Dr. Wilkins was my first mentor in the field of health equity. And as she has for so many, she has transformed the way that I have approached research and clinical care, thinking about the changes necessary to improve health equity. Thank you so much for joining us tonight, Dr. Wilkins.
Thank you, Dr. Spaluta, for the kind introduction and for the opportunity to be with you all this evening. I'm really just enjoying hearing my colleagues, so I had to remember for a minute that I'm supposed to speak as well. I wanted to focus my time talking about some of the work that we're doing at the institutional level. And as Dr. Betancourt has mentioned already, many organizations are starting to do this work in different ways, and I think it's important to really share what we're learning as we go on this journey. So at Vanderbilt University Medical Center, we made a commitment to health equity more than 2 years ago. So I've been in the role of Vice President for Health Equity now for, and of course, in the last 7 months, lots of things have changed, and we've had many shifts, and also certainly had a focus on health equity and COVID-19. I think importantly, as we start to really take a hard look at what our institution will do to really address the systemic and institutional racism that has been identified, well, certainly it's been identified for a long time, but that we're really, it's at the forefront of our minds, and we're really starting to address it. I wanted to point out some of the things we're doing and things that I think are really important for those doing this work. First is training and what racial equity is and how to actually use an anti-racist lens, not just a one-time training, but long-term change require also coaching, and so I'll talk a little bit about that. We also need to have, though, the really commitment to addressing inequities and policies within the institution, and considering how we'll actually de-implement, change, transform the way that we do work. And that needs to come with tracking, evaluation, accountability, and transparency. The third piece, I'll spend the most of my short time really talking to debiologize race. This is something that I hadn't expected to be such a challenge, but as we start to have more of these conversations and really ask people to stop looking at the superficial, which is often still blaming people's behaviors as well as lack of access to healthcare as really the primary reasons that are driving inequities, and failing to really look inward at the policies, but also at how we are, what we believe about race and racism, and our inability so far to really make it a core piece of our curriculum. We teach health professionals, how we train residents and other health professionals, what we're doing in clinical practice, and also how we actually approach health and biomedical research. So in July, our CEO and Dean of the Medical School, Dr. Jeff Balzer, issued a statement really putting forward our commitment to dismantle racism and the 5 initial steps that we're taking. And a part of that is having more specific recommendations to lead the work, to push the work forward long-term, and training. So far, we've actually had a full day of training for more than 70 seniors. That the chairs of departments, including our chair of radiology, chairs of basic science department, our CEO, deputy CEO, CFO, COO, anything with a C in front of it, those individuals needed to be a part of this training. And we'll also be providing to our VUMC board. And I think that's critical, that really is understanding what we're talking about, the work that we need to do ahead. And then we have other ongoing related to the need to start dismantling, changing our policies and practices. We have already de-implemented use of the race coefficient in calculating EGFR, and that happened in July. And so we're looking now at their algorithms that use and considering how we'll actually stop using those as well. We've changed our curricula. The medical students are also having first-year medical students in their first week of class have already key training and education related to health equity as well as anti-racism, and we've developed a hub of resources to support this. Our racial equity task force is led by 3 co-chairs representing our staff, our students, as well as our clinicians and faculty. These are amazing individuals who have given quite a bit of their time so far. We call for individuals to volunteer for this task force, and nearly 100 individuals volunteered. We've announced that group of about 30 and now have 7 work groups that are up and running with a goal of actually having key recommendations to our leadership by the end of this year. We anticipate that those recommendations will include a focus on what institutional infrastructure needs to be in place, what additional resources, who should be leading it, and how we'll actually have a plan, again, for accountability and long-term tracking of the work. As I mentioned, the things that has been, unfortunately, really more challenging, I think, than I expected it to be, is that many individuals are still conflating race and ancestry, and there's this unfortunate presumption that race is somehow tied to biology and genetics, and we continue to have these delineations and presumptions that are really false, and I think that is hampering our ability to make real progress, not just in racial equity but health equity, as well as discovery. We continue to use biased approaches and ways of thinking that don't really recognize race to the construct that it is. It is not biological, anthropological, or genetically based, and really focusing on these external features, facial features, hair, skin color, which are all, of course, very superficial and don't, even though those traits that I'm talking about certainly are due to genes, that does not mean that those same genes that affect the coiliness of our hair are responsible for some biological difference or physiological difference other than skin color tied to how you metabolize vitamin D from the sun. And so these challenges with our inability to really take a step back and think about when did we first learn about race, how did we learn about race, and really forgetting that, or never learning that in the United States in particular, racial and ethnic categories are primarily used for oppression. The idea that individuals who were enslaved and their descendants were segregated and marginalized, and the unfortunate massacre and stealing of land of American Indians and indigenous people, and the fact that we use questions to understand race and ethnicity, and the only ethnicity that we acknowledge is or identify is Hispanic or Latino, Latinx, really is a way of identifying individuals from those backgrounds to marginalize them in some way. And so I think we have to reject that wholeheartedly. We need to teach this in health sciences education. We need to demand that our clinicians understand, why they're asking race, what it means as a proxy for social determinants of health, as a proxy for racism, and stop limiting it to, again, some biological aspects that aren't true. These beautiful young ladies on the cover of National Geographic are twins, yet they likely experience life very differently. Their experiences with discrimination and racism and the opportunities they have are not due to their genes, but due to how the world is viewing them externally. The conflation again with history and recognizing that 6 individuals here in this panel percentage of ancestry markers from different parts of the world, but may have different racial or ethnic identities is really important to consider. Racism and creeping into medicine isn't new. It's been around. We really have to reject this. This is a story about spirometry and ties back to slaveholders who used data and that was not really reproducible to try and justify individuals being enslaved. And of course, we have this long history of hypodescent, of putting individuals who are of mixed heritage into a racial category or ethnic social class that is deemed to have less an inferior status, being marginalized, and race really being one of the most imprecise variables we use in human research and in medicine. That I can have one Black great-grandparent and be identified as Black, or I can have 8 and be identified as Black. So, these things that we have to really understand, that eugenics and, measures of head size and facial features that were tied to, skin color are really underpinning a lot of what we're seeing and how we use the words, the terms race and the categories today. And at some point we have to, again, step back as scientists, as physicians, as health professionals, and begin to separate these and recognize that while these things were happening, while people were being put into these categories, they were being marginalized and oppressed and massacred, and all sorts of horrible things happening. And now we're still blaming those individuals for what was done to them. So I will stop there and hope that as we move, we can begin to think about, again, more ways to debiologize race, to recognize it as an important social construct. It has meaning. Doesn't mean we shouldn't use it, but we should recognize what it is and know why we're using it. So thank you.
Thank you, Dr. Wilkins. Thank you for speaking on a topic that is so difficult and challenging for so many to conceptualize, and making everyone aware of the importance of understanding race and racism and the historical impact and significance of it. So I would like to again invite Andrea Barandi-Kitts for another reflection from the patient perspective.
Okay, let me go ahead and share my screen. I guess it doesn't like it. Okay, so we're at part 2 now. So what I'm going to do is I'm going to try and bring this down a level from talking the same topics that Dr. Betancourt and Dr. Wilkins were talking, but really trying to apply it directly to radiologists and what radiology can do. So as Dr. Betancourt said, the COVID-19 pandemic has put a highlight on health disparities in the United States. Latinx were 4.4 times more likely to be diagnosed with COVID-19 than whites, Blacks 2.3 times, and Native Americans 4.2 times. And with COVID-19 dramatically increasing the use of telehealth and virtual care, we really need to be aware of the digital divide. Right now, the current explosion of telehealth use is going to leave out 25% of the population, those that need it the most: rural populations, older Americans, low-income populations, and racial and ethnic minorities. Telehealth, the way it's being implemented now, is going to leave out people that have issues with technical literacy, health literacy, English language proficiency, hearing limitations, and don't have access to smartphone ownership or broadband access. So the protocols and systems we're building now don't address any of these and are likely to result in increasing health disparities. I'm involved on a lot of telehealth committees for different academic medical societies, and this is something that is only now becoming to be realized. So how can we address these types of disparities? We can provide equal supports for everyone. That's what we've been doing, sort of. However, equal treatment doesn't equalize access or outcomes. We can provide personalized support. That way everyone gets what they need for equity. That's what we're talking about going to. Or we can address the systematic barriers and remove them so that additional support is not needed. And that's justice. And that's where we need to go. Let's find a way to remove the fence. As healthcare professionals, you know these disparities exist. We just talked about them. As patients, we see and often we're impacted by the disparities, either individually or for our loved ones. And now, the silver lining with the pandemic is that it's exposed these in broad daylight for the whole world to see. And it's given us an opportunity to really do something about it. So radiology is involved in all aspects of patient care: screening, diagnosis, treatment, surveillance. I don't think there's any aspect that doesn't have radiology involved in some manner. And guess what? You have the right skill set to come up with the solutions that are going to remove the barriers. You're going to be able to get rid of the fence. You're at the forefront of AI. As a profession, you're IT and tech savvy. You're involved in the full continuum of care. And radiology societies really have very strong advocacy networks that have been built up. Who better to lead the way to reducing systematic health disparities? So I have some suggestions on how radiologists can help. First, we need to find ways to facilitate and enable follow-up care for patients that have already had a radiology procedure and need follow-up. These individuals are known to you. We've seen them. They've been in our system. The answer may be in using AI and improved interoperability of EMRs to identify these individuals who seem to have fallen through the cracks and reach out to them. A recently published article in the Journal of Radiology describes the use of AI to reduce no-show rates for MRIs, or as better said by Ephraim Flores, missed opportunities for care. Also consider using AI to identify individuals at risk to follow up and take proactive actions to help arrange the follow-up before the patient misses the opportunity for care. We had a patient that routinely came in for her annual mammograms. She was also in a high-risk category for lung cancer, and she had gotten a baseline scan. But she did not continue annual screening for lung cancer despite coming in for her mammograms every year. 3 years after her baseline CT scan, she was diagnosed with late-stage lung cancer. How do we prevent this missed opportunity for care? I personally think these would be great topics for Data Science Institute AI use cases, so someone should take a note on that. However, even with health insurance and a regular source of care, access is not always easy. There's some really simple practical things, and I think Dr. Betancourt touched on some of these. People can't always take time off of work. Do we have weekend and evening hours? Limited English proficiency. Do we have interpreters available to help? Transportation, just getting to the location is not always easy. Do you provide a ride share? Is there public transportation? Do you have free on-site parking? Some sites have made arrangements for rideshare services such as Uber or Lyft for their patients. From the standpoint of telehealth, we need to help our patients find resources for free or low-cost broadband access. We need to help them find ways to get digital devices. Maybe we talk to the Apple rep and say, hey, you know, can you provide some to help us with our patients that are in underserved populations? We have to train people on accessing and using telehealth tools. We need to have interpreters available during telehealth visits for those who prefer a language other than English. In radiology as a profession, I think you need to stand out and advocate for universal broadband access and also for Medicaid expansion to be implemented in all states. These are just some pretty simple, straightforward things. So in summary, COVID-19 has highlighted long existing health disparities. I think Dr. Betancourt talked about all of these. And we can no longer ignore the societal constructs that result in health disparities. Radiology is well positioned to lead the effort to reduce the disparity gap. And now is the time to make this happen. Thank you.
Phenomenal presentation, Andrea. Very important topics, and you're highlighting the importance that we are here because we are here to do what is best for our patients. One of the points that you mentioned is also how technology can potentially become a barrier to care. And unless we leverage it to really advance health equity. And that leads us to our next speaker, Dr. Arun Krishnaraj, who's an associate professor of radiology at medical imaging at the University of Virginia, where he serves as vice chair for quality and safety. He's the director of the Division of Body Imaging and chief of the section of abdominal imaging. Also, he's director of body procedures and the fellowship director of body imaging. He also serves at the ACR Patient and Family Center Care Commission as chair of the commission and a thought leader in our field. Thank you, Arun, for joining us this evening.
Thank you, Dr. Flores, and thank you to the ACR and the AMA for helping to sponsor this outstanding group of panelists for which I feel an honor to be a part of. Today, I'm going to be speaking about some of the issues around technology that you heard Andrea and many of the others speak to. So, first I want to say technology has improved our ability to connect with each other, especially during this pandemic. And in the field of radiology, advances in technology have markedly improved our ability to diagnose pathology and provide care over wide distances. Unfortunately, technology has also driven a divide between the doctor-patient relationship. Too often, physicians' faces are buried in their computer screens, while patients are left wanting for a connection to help ease their anxieties about the bewildering world of modern healthcare we all face. This situation is even more pronounced in our marginalized populations. So what I'd like to present to you tonight is one way our team at the University of Virginia is utilizing technology to help bridge this divide. I'd like to acknowledge my team members who are working with me on this project, and we have no disclosures. Informed consent is a required part of any medical procedure. It is codified in law and requires 3 basic criteria: that the patient must be competent, adequately informed, and not coerced. It's the conversation that we as physicians have with our patients to discuss with them the risks, the benefits, and alternatives to procedures. but most important, it is the process designed to empower patient autonomy and foster a patient-physician partnership that allows for shared decision-making. However, informed consent is not always performed in an ideal manner due to a number of constraints. One, we are often limited by time when having these conversations. Moreover, patients have varying levels of comprehension and health literacy, which further complicates the matter. And also, the informed consent process lacks standardization. You have attendings, residents, and in my setting in a teaching hospital, and you have people who are great with folks and speaking with folks, and other people who struggle in that setting. And I would argue that this process is even more suboptimal in patients with lower English proficiency. According to the US Census Bureau, 20% of the US population speaks a language other than English at home. Bridging this language barrier is necessary to avoid clinical errors, provide patient-centered care, and comply with legal and regulatory mandates. This leads ultimately to diminished patient satisfaction and, unfortunately, less patient-centered care. As noted earlier, patients are often anxious and fearful for their medical procedures. What patients expect is a caring physician who will walk them through this process. And while this may occur for English-speaking patients, our patients with lower English proficiency are often met with this to comfort them: the ubiquitous interpreter over the phone line, the faceless voice that speaks to them about what's going on. Last week, I saw this tweet on Twitter, which I think does a good job of capturing how alien patients with lower English proficiency are made to feel in our healthcare setting. And I think we can all relate to this situation. Says Dr. Rodriguez, "Gotta love it when they call a patient altered. Then you go and chat with them in Spanish and they give you a history. Like he's not altered, he just doesn't know English." So in an effort to improve how we conduct informed consent on our busybody procedure service, we decided to leverage the technology of computer tablets to partner with Holven Group, who have furnished us with professionally designed, patient-friendly, procedure-specific videos. We are currently assessing its impact on our service, which I'll share with you over the next few slides. So our study consists of patients who undergo image-guided procedures, so either using the CT scanner or the ultrasound machine to advance a needle to do a procedure such as a biopsy or something like that. Patients who come to our service are randomized to either receiving informed consent via the standard process, which is a discussion with a physician, or via the tablets preloaded with procedure-specific videos. Following this, patients in both arms are given a survey. Here are some examples of what some of those videos look like in English. The survey assesses their understanding of the risks and benefits of the procedure, as well as post-procedure instructions. We also gather some demographic data with that. And while the data I will share with you is for our English-speaking population, we are currently conducting our study with Spanish-speaking patients. However, the numbers for this population are currently limited due to the difficulty enrolling patients during the pandemic. Here are a few screen captures from our Spanish language videos. While our results are not currently statistically significant, they do show a strong trend toward greater understanding among patients who watch the videos compared to those who underwent the standard consent process. We also note that the population who saw the videos had fewer questions than the in-person group, suggesting that they understood the content explained to them by the videos better than the in-person conversation. Also of note, the positive responses from the video group were more tightly clustered near the top than the standard group, as you can see from these two tables. And while the standard informed consent group showed decreasing understanding, as you see here, with each different age bracket increasing, we did not see this trend as strongly in the video group, suggesting this did have an impact on age. So there is a trend, again, not statistically significant, but our data suggests that patients who watched the videos prior to our standard informed consent process felt they understood the procedure and its details better than those who did not. They had fewer questions related to the procedure, and they were more consistent in their scoring highly of the entire process. Also, all scores not exposed to the video showed a trend of lowering score with increasing age, a trend not observed among the video exposed, suggesting again that as patients age, they have possibly less understanding with what's being discussed with them, and that our videos assist with this. And the average response, while not statistically significant between the control and intervention group, accounting for age, gender, and level of education is likely a reflection rather of our sample size than necessarily the way that this study was performed. So in conclusion, procedure-specific videos rich in animations, and again, this is important, aimed at an 8th grade comprehension level so that we can reach the most individuals possible, is an important educational tool to complement what we do as standard in consenting patients via our verbal consent process. What is good about the videos is they allow for consistent and comprehensive discussions of what is going on specific to that patient, specific to that procedure. And this is particularly helpful in older patients in helping them better understand the complex procedural details that are often involved in an image-guided procedures, and ultimately, like I noted earlier, allows for improved shared decision-making. And I'm excited to share with you the early results from our Spanish language speakers, who I think are at increased disadvantage from the standard informed consent process, are showing benefits in understanding and patient satisfaction using this video-driven format of informed consent. We can and should do better for all our patients, especially those with lower English proficiency. I hope in the future we find more ways to use technology to improve the doctor-patient relationship, rather than allowing technology to create a divide between us. Thank you.
Thank you, Dr. Krishnaraj, for sharing your really innovative work to leverage technology and radiology to care for our patients, especially making a difference for patients who may have otherwise been marginalized. Our final speaker for the evening tonight is Dr. Ruth Carlos. Dr. Carlos is a professor and assistant chair of clinical research at the University of Michigan. Her research focuses on equitable care delivery and expanding models of evaluating race and racism in clinical trials. She is the editor-in-chief of the JACR, and she will discuss health disparities and, importantly, the cost of care. Welcome, Dr. Carlos.
Thank you, Drs. Spilluto and Flores, for this invitation to participate in such an illustrious group of really leading thinkers in health equity. And thank you to the AMA and the ACR for the support of this activity. In talking about financial health and health equity, I will attempt to synthesize some of the concepts that have been brought up by the previous speakers and apply them to some of the most pressing issues that are preventing the range of individuals from getting the care that they deserve. These are my disclosures. Really, the 5 principles of quality care as we build better and more precise diagnostics and treatment is that we also must be able to provide culturally appropriate services and support the right patient, the right test, the right treatment, the right time, and for the right price. But there are many barriers that stand in that way. Dr. DeMaio and I come from the same area, and I used to take the Garfield line from the University of Chicago in the South Side, where life expectancy is 69 years, down to, or up to the Art Institute, a distance of 10 miles and more than 15 years of life expectancy. These are the social determinants of health that we are increasingly identifying as playing a large role in health outcomes. For example, economic stability. Can we afford care? Neighborhood, can they get to care? And the health system, can they access culturally sensitive and appropriate care? And note what does not appear in this model, which is race. We tend to think that our health outcomes are mediated by patient-level variables, what I do and what my genes are. But the individual is nested in the family, and that family is nested in a neighborhood, and that neighborhood is often populated by people who look like us, who think like us, and who have access just like us. But what if there are different neighborhoods? For example, in high-density neighborhoods, you can have multi-generational households attempting to protect their abuelas and their abuelos, their titos and their titas from the risk of COVID. Residential density leads to difficulties in safe distancing. Residential segregation that has been emphasized by policies such as redlining have led to disparities in water and air quality that have a direct result on one's health and healthcare. High-density work environments, such as working in an Amazon fulfillment center, 0 contract hours for a McDonald's frontline worker, no sick leave policies or employer insurance availability limits one's ability to participate in one's care, and transportation inequity and food desert only compound the difficulty, all of which leave individuals and families financially fragile as they attempt to manage their day-to-day lives, and it leads to financial burden and toxicity when stressed with illness. So let's talk a little bit about the physiology of scarcity. We could be food insecure, time poor, or resource poor, and that leads to a difficulty in making good decisions over a long period of time. And just as an example, someone who has adequate health insurance and has the resources to pay for any incidental out-of-pocket costs that might arise might have a positive lung cancer screening. The next thing that they will do is schedule that follow-up appointment and go on to the next decision that they have to make. Someone who is resource poor, who has a high deductible health plan, who works at a 0 contract hour job, might need to debate about whether or not they can afford to schedule that appointment. And if they schedule that appointment, that means taking a day off from work and losing their 8-hour shift. And if they lose their 8-hour shift, well, they can't pay for their child's asthma medication. So then it becomes a choice. Should I work up my possible cancer or give my child an asthma medication? And just in that encounter, they have gone through multiple decisions that wear on one's intellectual reserve, which leads to decisions that at that moment the decision is made is entirely rational, but may not support one's long-term health or economic goals. And in fact, this physiology of scarcity from the outside can lead us to think, why does the and fill in any group, any disenfranchised or minoritized group in that bracket do X, Y, and Z, which we from the outside do not necessarily see as the quote unquote right decision. But what is interesting about the physiology of scarcity is that it is not related to race. And evaluating race as a dimension that explains the inequity that we see in health outcomes is easy, it is lazy, and it masks the bias implicit even in how we frame the research questions and how the inferences are drawn from the results that we have. As if minority patients have some different biology for which we haven't found the magic pill, or worse, are behaviorally responsible for their poor health outcomes without contextualizing the impact of living in a gendered, racist social structure. We are really talking about racism, as the other speakers have already noted. Race is an easy surrogate. It may be a surrogate for ancestry, our lineage, which might be what is driving some of what we see. And Bond et al. Have attempted to look at ancestry and define the relationship between that and some of the genetic markers in myeloma. And this leads to some later work on the biobehavioral model for cancer development. On the left side, we have linkage of social determinants of health in blue, including life stressors, psychological response and one's support, as well as health behaviors, on the biological effects of cancer in orange, which are neuroendocrine regulation, immune response, and modification of biological cancer risk, all of which then mediate cancer development and response to treatment. We have further extended this model to explicitly integrate social constructs such as race and wealth, and the physiologic dysregulation due to living in a structured racist and sexist environment that contribute to outcomes that we have previously observed to be disparate along gender lines and race lines. We have termed this allostatic load, which leads to cardiovascular dysregulation, immune dysregulation, and metabolic dysregulation, which we posit to mediate these outcomes that we see, such as tolerability, survival, and cancer recurrence. Constructs such as financial burden, especially that attributed to care, can further impact allostatic load. So when we begin with those who are financially fragile, then expose them to test or treatment, depending on their level of financial reserve, they can experience financial toxicity of care, which then becomes cumulative to the point where they may not be able to afford the care, which we term as non-adherence, and patients experience debt and bankruptcy. And then this becomes a cycle as one continues to participate in the medical complex. And we are complicit. Even when we try to deliver guideline concordant care, those who are financially fragile often suffer financial toxicity at higher rates than those who have financial reserves. And this is exacerbated when we expose them to overdiagnosis, overtreatment, or more testing because we are uncertain and seek diagnostic or therapeutic certainty. And at least for cancer survivors, the financial burden is severe. 28% of survivors say that they have high out-of-pocket costs. They have missed 22 more days of work. They have depleted their assets and entered medical debt, with bankruptcy in 1.7% of cancer survivors within 5 years of diagnosis. This leads to significant financial stress, housing insecurity, food insecurity, and job lock, where they cannot leave a job that they have a difficult time working in because of their cancer treatment, but they cannot leave because they cannot miss employment, or worse, lose their insurance. Higher copayments lead to lower medication adherence, and we see this most frequently in aromatase inhibitor discontinuation for early stage breast cancer. Patients who have less financial reserve have increased symptoms and report worse physical and mental health and lower quality of life. Increased debt and bankruptcy have led to increased mortality, at least in a small study in the state of Washington SEER database, with 2 to 2.5 times increased mortality for those who claim bankruptcy among colon cancer and prostate cancer survivors. When we looked at financial burden and the contribution of imaging in our outpatient settings surrounding the University of Michigan, we tend to think of our catchment area as being fairly well educated and reasonably well resourced. We enrolled those who were undergoing CT or MRI, and we asked them about their worry, about their test out-of-pocket cost, whether they had used financial coping strategies such as using debt or savings to pay for medical care, and whether they had care non-adherence in the past, taken less medication, did not fill their prescriptions, declined tests, or delayed visits. And what we found was patients who, only 17% of patients that we queried remember even being told what their out-of-pocket costs were, and 22% were worried about their out-of-pocket costs for CT or MRI, which is a fairly high number that I did not expect in our area. 35% had used at least one financial coping strategy to manage the cost of care, and at least 10% had experienced one episode of care non-adherence. After controlling for standard demographic variables such as race, the presence of insurance, age, ethnicity, what had significantly contributed to financial coping mechanism use was their worry about out-of-pocket costs. And if they were worried and remembered that they were told what their out-of-pocket costs were, there was an additional effect of the interaction between the two. Worry about out-of-pocket costs also increased the likelihood of non-adherence by almost 10-fold. So what are some of the opportunities to take action from a radiology practice perspective? can we use radiology imaging centers or outpatient imaging encounters to screen for financial fragility? Is there a way to integrate into our existing work process 1 to 3 questions to screen for financial fragility? For example, are you worried about today's out-of-pocket costs? And for those who are negative, they would then go to their next appointment or home. And for those who screen positive, is there a way for the radiology practice to develop a referral system to link patients who are financially fragile with their institution and their institution's financial navigation services? A way to make this even more compelling from the practice perspective is that, can we measure the reduction in unrecovered patient cost share by facilitating this linkage of those who are financially fragile with financial navigation and counseling services? Because to do good is good business. Other opportunities to take action. We need to recognize the implicit bias in social constructs like race and wealth as explanation for what we see as disparities in health outcomes. We need to change the research perspective in how we evaluate the effects of racism or gender bias. We need to take ownership of the financial distress we cause our patients and work on ways to mitigate that by managing overdiagnosis and overtreatment. Ultimately, justice will not be served until those who are unaffected are as outraged as those who are. And I call on this group to be as outraged that our ability to deliver the best possible care is so disparate across our country. Thank you.
Thank you, Dr. Carlos. What a phenomenal finish to this evening, and all the speakers. Tremendous message, like really a call to action of what we can do, and not only that, but also putting everything together of how financial toxicity really directly impacts patient care and health decisions, and how they perpetuate health disparities, and what can we do to assist our patients overcome some of those barriers. Just to, as we are wrapping up this evening, thank you everybody for being here, and all the panelists for tremendous, very rich discussion of high priority topics that influence all aspects of radiology care and healthcare in general. I just wanted to point out the participants just to also check the chat box for the resources provided by the American College of Radiology for the upcoming health equity special issue from the Journal of the American College of Radiology, our ACR bulletin issue on the health equity, and also additional resources on health equity from the American College of Radiology in collaboration with the American Medical Association. Now, as part of the, as we're wrapping up this session, just wanted to briefly move into the Q&A session from some questions from the audience. I wanted to bring up one of our questions is that this is more directly directed to Dr. Betancourt and Dr. Wilkins. When he talks about structural racism, it's so deep rooted in our society, and we need to find ways to accelerate change. At a federal level, do you think that using financial type incentives, maybe tying reimbursement or using grant funding, can help? Wondering, Dr. Betancourt, if you want to start, or Dr. Wilkins.
I can let Dr. Wilkins go first.
Yes, thank you. I think that incentives could help, but they're not really getting to the structures. So if we really want to address racism at its deepest core, it's going to need more than money. It's going to need a different way of thinking, a different way of distributing resources, but also we'll need to stop penalizing people. And I think Dr. Carlos made some great points about why we need to understand how people respond when there is scarcity. And so if we continue to make rules and policies based on what we think people should have or what we have, then we're never really going to get past some of these policies and structures that are in place.
Dr. Betancourt, do you want to add to that?
No, I think with the issue of structural racism, it's interesting because I do believe it requires local efforts, right? I mean, these are issues that have fly under the radar, as I mentioned, for many, but you know, the way I'm viewing it at MGH is, you know, our goal is to literally crowdsource, right? People who are most impacted by these. We hear things that we weren't aware of, we didn't understand, we you know, didn't take time to dig into. And so, you know, this is about creating sustainable processes and discernment and a deliberate effort to be able to identify these issues and then dismantle them. And again, I believe that really comes from the ground up. This is from the ground up.
Thank you both for.
Could I make a comment on that? I would just say that anything we need to do, anything that we're going to go forward with, you have to include the populations that you're doing it for. Because if the people who are impacted most are not involved in the solution, you're going to sub-optimize it and you're going to come up with something that isn't going to work. So I would just really, really ask everybody to include different people, patients, individuals from the different populations from the ground, from day one, not when you have the solution to comment on it, but from the design of the solution and all the way through the process as equal team members. Thank you.
Great point, Andrea. Thank you for reminding us all how important it is to have such a diverse collection of thought for all of this work. Dr. DeMaio, there was one question specifically in the chat box for you, a comment on your statement of discontent with business as usual, and the question is liking that comment and saying, do you have any input as to particular practical mechanisms for real change for physicians that we should be pushing for, even for those who are in private practice?
Yeah, I guess my first point would be about the voice of physicians, right? You have a remarkable platform of power and privilege and authority in society. Just the fact that you're having this conversation and centering racial and ethnic and other inequities in health is so fundamental and can make a real big difference. Your ability to partner and collaborate and build coalitions with public health departments, with community-based organizations, elevating their concerns and recognizing the centrality of health in all aspects of social life, right? Whether we're looking at community development, gentrification, we're looking at living wage and income inequality, the ability of the healthcare system to bring health into those equations is so fundamental for spurring change. And then data, right? Like tracking changes over time, really paying attention to inequities within your practice, within your health system, and calling out those inequities as being produced, right, by poor policy and poor algorithms and poor systems, all of which can and should be changed over time. Thank you for the question.
Thank you for your excellent answer and for your input here. And now I'm going to move on to a question that is more specific for radiologists and how, so excellent overall strategies from panelists and you're giving everybody input on how to improve health equity. Wondering, and this is more directed for Dr. Carlos, Dr. Krishnaraj, and Andrea, and like Andrea Brondi, kids, provide some specific ideas or strategies that radiologists can bring into their practice and for their patients to advance health equity.
After that's a great idea. I think Andrea did a really nice job of showing how radiologists sit at the kind of inflection point of where everything is going on in healthcare, and they have a unique opportunity. You know, I highlighted using technology, but more than technology, I think that it's important for radiologists to connect directly with patients. We're seeing everybody come through. We're somewhat objective in the sense that everybody looks gray in shades of gray on a CT or an MR. So while pictures are included in the popular EHR vendors right now, I don't think they necessarily drive the way we do interpretations. But as you have highlighted in talks before with these missed imaging care opportunities, I think that radiologists have a unique opportunity to get out of the reading room and meet with patients and try to overcome some of those barriers when we have the skill set to do so. Andrea again brought up a point of a patient being lost to follow-up for lung nodule. And many radiology departments across the country have embraced that responsibility of follow-up for incidental findings to fall upon the radiologist. And if the radiologist goes and discusses it with the patient and connects with them, I think they have a much greater opportunity of not overlooking that potential finding and ensuring that good care is possible. I also think that radiologists, such as yourself and Dr. Spaluto, that have ethnic backgrounds that aren't necessarily highly represented in the field, speaking up on the issues of how different ethnicities are treated and the care that they get and bringing that issue to light also has a huge impact.
Yes.
That is, it's an interesting question because we all want to do something, especially in areas that we have a locus of control. So from a caregiver perspective, we all practice in diverse institutions. And I would ask us to be mindful of the words that we use to the people around us, even when we don't think other people can hear, because what we say in private to other people who look like us inform how we treat our patients, whether this is conscious or not. And if we make it a practice to decrease ascribing specific characteristics by race or by gender or by any other criterion beyond being a person, that may go a long way toward being able to treat our patients as individuals rather than as a member of a class. Taking a step back from a research perspective that will then inform the practice of medicine, I still find it incredibly dangerous that the populations that are used in many of the AI algorithms that will drive our care in the very, very near future are derived from 3 or 4 states in the US, rather than representing the US broadly. I also find that there is an absence of a description of the population itself that is used in the training sets and in the validation sets that do not allow me to understand the bias built into the algorithm just by how they assembled the sample. And I'll give 2 examples in very recent memory. One was just announced a few days ago, where an algorithm was able to classify people's faces by race, which to me just meant we trained a machine to do 19th century phrenology. It's a 21st century equivalent. There's another algorithm that is being used in the public justice system that predicts the rates of recidivism among individuals and automatically assigns sentences or automates the sentence suggestion process. And this is based on race, and it's tied to the frequency with which they are rearrested, which seems incredibly biased because we know that African Americans are already at a higher rate of being arrested even if they are innocent. And that is now informing the length of sentences because we have codified a biased way of thinking into what we ascribe as a quote unquote judgment-free mechanism, which it isn't. And that is where I would want us as radiologists to pay attention to the applicability of these instruments as we implement them into populations that may not look like the training set or the validation set.
Yeah, that's a really good point, Ruth. we have to be very, very cognizant of all the biases and potential pitfalls around the implementation of AI. Ethics is a big deal there, and we have to figure out how we're going to do that. I will say that one of the key things, I think, is what I said before. You know, I gave a whole list of things that radiologists could do. One of the key things is making sure that we involve the people that we're helping as equal team members in coming up with the solutions. Because I think that's really the way forward. I mean, we can use AI, we can use technology, we can use all of this, but if we don't involve the people that we want to help the most, then we're going to sub-optimize and potentially actually increase disparity by making it more difficult.
Thank you. Thank you. I could continue this conversation for the rest of the evening, but unfortunately we've approached the end of our allotted time. But thank you to all of our speakers for these wonderful talks and this powerful discussion of the question and answer session. I really appreciate the strategies you've all presented to move forward with health equity, including taking a community-centric, team-based approach, really addressing racism in our communities, leveraging, understanding, and being careful of what technology can do for us.